Let's turn to relapse follicular lymphoma and the decision when to treat a patient after they've already had a therapy. We have these criteria that have been written down for frontline, the normal indications for treatment, bulky disease, cytopenias, pleural effusions, things like that, symptoms. Nathan, are you using those same criteria in patients with their second time?
Yeah, so with the exception, if I go back to the front line, I do tend to use GELF. I'm pretty religious about using GELF criteria to determine when patients require treatment. In fact, when I first see patients in clinic, I tell them about the GELF criteria, so they're actually kind of following along with me when we're looking at scans together and following their blood counts, and they kind of understand when we're getting close to needing treatment. But then once they have treatment, I often think about other factors when I'm initiating a second or third line. That'd be the kind of how long their first relapse lasted, their first remission lapse lasted, how it presents, either as a large, bulky disease or as low volume disease, as well as how the patient feels about the relapse. So for example, if I have a patient that receives induction chemotherapy with a Rituxan and they go 8 years, I'm probably not going to do chemotherapy again. I'll just give them a little Rituxan because they've shown to me that they're a very low risk patient, and I might use that Rituxan earlier, even before they have progression of disease or symptoms. And again, because I get the sense that I can control it with not a lot of therapy. I do think that I do use the GELF as a hard and fast. So I mean, if they have symptoms, I'm not going to watch and wait patients in the relapse setting. But I guess what I'm saying is I may treat patients a little earlier before they actually develop GELF criteria in the relapse setting, depending on how long their remission was.
I mean, it's rare they'll have better kinetics on their recurrence than they had in their initial presentation. So if they quickly progress to needing therapy the first time around, you can kind of see that's going to happen.
As we've seen from Carl Luxulo's data, that patients that go at least 2 years, they're probably never going to die of their disease, and that's really nice because I think that what that tells me is that most of these patients had very heterogeneous therapy in the second and third line, but despite that, their survivals all were very, very good long term.
So do you stop doing surveillance imaging, I guess is the question. I think about it as, if we're not doing surveillance imaging, are you capturing their relapse on physical exam or some laboratory finding or a complaint that prompts a scan, versus doing active surveillance in an asymptomatic individual and capturing, borderline GELF criteria? You don't then know the velocity of that change, and I think that's an important piece. If you're not doing scans, that you may say, okay, I acknowledge that you have nodes that are growing, but you feel well. Maybe we look again, and to your point, if it's after 2 years after their first line of therapy, then that might be a slow relapser, and it may have been relapsing for a very long time.
Yeah.
I was just going to say, I would suspect that someone who's got a known history of follicular lymphoma, that the burden of disease that they present with at relapse on a clinically detected relapse is probably lower than when they were diagnosed in general, because you're seeing them, you're examining their nodes, they're more attentive, et cetera. So even in the absence of scans, I think that the first relapse tends to be diagnosed earlier. The exception maybe being transformation, when the patient will come in with a bulky mass or rapid progression. But I think either way, I think if your approach is to use more minimal treatment or to take your time with a first relapse patient, you're probably going to find those at a state where the patient has less disease going on.
The challenge that I'm having is that, first of all, this whole early progression of disease is something that we are only now aware of. And so sometimes you'll have somebody who progresses early, but they don't actually need treatment. So their prognosis is not going to be great, but it's not really clear that you need to intervene at that time. So I think that'll be maybe the next generation of questions.
I think it's probably an important one.
Yeah.
The other thing that you're bringing up here in this discussion about scans is, we live in this era where everyone wants us to do less scans, and of course they're not without harm scans. How are you, at the same time, you can't really tell if someone progresses unless they get, very symptomatic. Have you changed how often you do scans, or if you do scans?
I try very hard not to do scans unless somebody has symptoms, changing blood work, or a changing exam. And, I think, again, I've just started to really take the long view. You look at some of these long-term data sets and know that they're going to be alive, 10, 15, maybe 20 years later. So I try very hard, unless they're part of some, particularly high risk, background, I try not to do the scans.
Does that matter, Nathan? Does that matter whether how far you out are from therapy?
so-
The first 2 years versus 5 years?
Yes, I may be an outlier in the group. I mean, I am still a believer in imaging. I think that what you mentioned earlier, I tend to do more intense imaging in the first year because I'm thinking about relapse. I'm thinking about transformation. Am I missing an occult transformation? So generally, I'll do a scan about 3 months after they finish their first therapy, and then 3 to 6 months again. And very quickly, I start moving to annual imaging if I'm kind of ruling out any aggressive course. And as you mentioned, if they have a fairly long relapse, fairly long remission, in other words, you're talking about 2 or 3 years, we start really reducing imaging, and often, when patients are several years out of getting, for example, just a chest X-ray and blood work and physical exam.
And this is all CT scans. Do you do a PET scan after therapy at all?
So in the United States, and I'll just say this, is that imaging often is dictated by insurance companies. And so I think PET imaging is actually a much better modality for following a follicular lymphoma patient. When I'm talking about PET, I'm talking about a PET CT. And current PET CTs have essentially the same amount of radiation as a standard CT. So again, I think that if I was to follow a patient and I could do whatever I wanted, I would probably be doing PET CTs in patients. But CT scans are currently what's approved.